first things first, we always like to really just cover this right out of the gate because we don't want to bury the lead. Why are we here? What is it we're really trying to say to you guys? Why are we doing this webinar? What is it? What is it that we have that we want to impart to you guys to make your lives a little bit better? So let's just cover that right out of the gate. And Pete, and by the way, guys, this is going to be a bit more of a kind of an unconventional webinar in a sense, and there's going to be a bit of a fireside type of a chat, right? We're just going to have these guys talk about a few different topics, and it's not going to be just reading off bullet points, right? So, Pete, I'm going to give you the first pass over at this, and Doug, if you don't mind following with any of your thoughts on this.
Yeah, so thanks, Cody. I think back to the question that was on the previous slide, why are we here? I mean, honestly, I think it's pretty simple, and it's something that every single person on this webinar experiences. It's the unfortunate reality that we all owe so much more for our healthcare. And I'd say the sort of follow-up reality that I don't think that's going to change, right? We're not going to go back to the days when commercial insurance covers more of our, all of our healthcare services. So the high deductible plans are probably here to stay. So unfortunately, we all owe a lot more for our healthcare. And I think the other part of that is that it's, not so unfortunate. It actually makes a ton of sense that, from the provider side of things, the systems that you have or the processes that you have aren't necessarily geared towards, or they historically haven't been geared towards, becoming more effective at billing and collecting from patients, right? I mean, rightfully, you'd spend more energy to make sure that claims are clean, make sure denials are worked. It's always going to be a bigger portion of your dollars. So it makes perfect sense. But, we really do need to try to find ways that providers can get better, at asking patients and guarantors to pay them. So, that's going to be the real focus of this.
Yeah, it's funny, when I started my first job in healthcare in 2003, my deductible was $250. And I remember when it went up to 500, I was like, oh my gosh, I can't believe it went up to 500. But, that's just the beginning, and little did I know. But it's funny because this happens every year. And a lot of folks are just like, all right, I just got to get used to knowing that I'm going to be making less money the first part of the year, and I'm not going to do anything different. So what we want to talk about more today is like, hey, let's challenge that. You need to really be thinking of your patient as one of your top 3 payers. Like Pete was saying, like, hey, we know what we got to do to deal with Medicare. We've got the challenges with Blue Cross and United, and we're preparing for that. We're getting into portals and we're doing things to try to automate. But when it comes to the patient collection piece, if you look at your numbers, they're going to probably be one of your top 3 payers with deductibles, co-insurance, copay, and we're not planning appropriately to deal with this time of the year when the deductibles are resetting, to have a comprehensive approach, an automated approach, a seamless approach to collecting from our patients.
All right, appreciate that, guys. All right, so moving on here, why traditional billing fails? Like Doug, if you want to keep just going on since you ended off on that last slide, go ahead.
Yeah, I mean, so in my role, I do a lot of just analysis on just different practices of all shapes and sizes. I look at workflows, processes, look at KPIs, and one of the biggest things I always see is the lack of automation and more manual processes when it comes to the patient collections and statement processes. And the first one there, monthly statements, that seems to be the most common. And if you go out and just look it up, like sending a paper statement is probably the most common way. I think it's something like 70%. And those are often just done monthly, right? So then you have the delay. I don't know, Pete, if you've had this, but I've gotten a bill from practice like 6 months after services were rendered. And I'm like, what is this? That happens common. So then your people are frustrated. You have patients who are upset with you and they're going to say something about it. And then what's really telling is that 62%, if you don't collect that money from the patient while they're there, the chances of you collecting it drops by 62%. I remember when I first sat down years ago to do a similar kind of presentation, it was 50%, right? And so now it's worse. And you have things that legislation where they're trying to get it to where medical debt can't count against you on your credit score. I know that was kind of held back last year, but that's also coming. So it just points back to the fact that we really do need to focus on this, not just for making extra money, but so your staff is not completely overwhelmed and burned out, and your patients aren't upset with you.
Yeah. The other thing I'd say is tactically, and we're going to talk about it some a little later on, or like Cody said, you guys will even see some things, but tactically, I think for a long time, of course, the market's been sitting here talking about, oh, well, we should, reduce paper, let's go digital, right? And then you'll have the paper provider say, well, okay, now I can provide you a method to text or email your bills. And so someone will say, okay, that's cool, let's do that. But then they still send a bill electronically once a month, right? So tactically speaking, I think against two things. One, yes, you should definitely in this day and age try a digital first approach, but you really do, and Doug made this point, you really do need to get away from communicating once in a 30-day period, right? You got to get away from that. You have to communicate more frequently, but also whoever you use, might be a service, might be a piece of software, they need to understand regulations well so that you don't over communicate. Like there's regulations around over communicating billing events to patients and guarantors. So you need to make sure everyone involved understands those rules. You need to make sure the systems communicate appropriately. But the other thing that I would say, and it goes to sort of the bottom left, talking about overwhelmed staff, whatever tactics you use, right, whatever solution you end up utilizing for this, you really should find solutions that don't just solve one problem, right? You got to find solutions that not only will help you, give a better patient or guarantor experience when it comes to billing and payment, but find a solution that's going to drive more payments. That should be the name of the game from the provider perspective, right? But also it should actually help your staff spend less time managing, the patient financial responsibility. And so there's a lot of different tactics you can put in play, and the right solutions think about more than one value prop, right? They don't think about just providing you text and email. That doesn't mean anything if it doesn't drive a better result.
Right.
Right.
And I do see that there are a few questions that are coming in, so that's excellent. So again, guys, along the lines of what Pete was just saying, that's usually where, like, hey, there's oftentimes a lot of hands that do get raised in these presentations. So if you do have a question, again, as a reminder, and for those of you that arrived a little bit late, you got a question, type it in over into the question panel. But for now, hold on, I have to, before I do this, I have to officially go to the next slide. Okay, there we go. All right, audience polls. So like I was saying earlier, we've got 3 polls that we're going to get through real quick, and I'm going to launch those out right now. So let's go to polls. Let's launch the first poll. Okay, so you guys should all see this on your screen right now. What happens to your practice or hospital, for that matter, cash flow in Q1 after the deductible reset, right? So what do you guys experience? Is this like your slowest revenue quarter? Do you guys actually see a dip, but you're still able to manage it? Or is it just chaos every single year? Or maybe you guys actually have it figured out and Q1 is all good. And in which case, if you've got it figured out and Q1 is all good for you, then hey, we should have you coming on and doing this webinar with us, right? So I see we're getting some responses. And if you are just listening to this over on the side, again, a reminder, this is an opportunity for you to go in and put your information in there. And I'm going to share this here in a second, and you can see what everybody else is doing. All right. So I'm going to give this just a second longer. All right. So Pete and Doug, are you guys able to see the results here? Okay, I'm going to go ahead and end and share the results. And all right, there we still got more people voting.
More
All right,
came in.
I know exactly, but just for time's sake, I'm going to end and share the results. All right, so you guys should be able to see these results on the screen right now. So Pete and Doug, anything here like that's surprising for you guys, or is this pretty typical?
Not shocking, I would say. I mean, not shocking, but I will say it's actually pretty encouraging that, the respondents feel like you've managed the way to get through it. I think the thing that we can help do beyond that or talk about is, okay, how do we help all of those go from manage your way through it to thrive?
Right.
Right. Like, how do you really take it to the next level and drive up, again, drive up the dollars collected, but also, drive down the time spent by staff.
Yeah, I've
Exactly.
done some analysis on this, like this, I call it a seasonality analysis, and Q1 is by far the slowest month revenue-wise throughout the year, and it's about 15% on average, but it could get as high as like 30-40% of your revenue drops in Q1 if you're not, thinking this through, and you're just like, hey, we're just gonna, hoard our money and, wait it out. We've even seen some practices that will, I meant to mention this on an earlier one. I don't know, Pete, if you've seen this, where folks will sit on claims for a month because they're hoping other claims will come in and hit the deductible before their claim. And all they're doing is making it worse. They're pushing the revenue out further and just crossing their fingers that when they do file the claim in a month, that it won't go to the deductible, and then they're just not going to, and then they won't have to have the conversation with the patient or deal with the patient out-of-pocket piece. But that's also not a great solution either.
Yeah.
All right, so poll number 2. All right, so here we are again. How do you currently bill patients for their portion, right? What are you guys doing today? So are you sending out, monthly patient paper statements are mailed out, monthly electronic statements by email or your lovely portal, which I would imagine a lot of you guys that are the more on the acute side probably have that fun portal from your EMR. Or you bill immediately after each visit, you do that in a digital way, or you bill immediately after each visit in a paper fashion, or our lovely last little part there, a chaotic mix of all of the above, and I don't know, whatever it is that I can do at any moment in time. All right, so excellent. Thank you guys for responding to this one. We're seeing some of the results come in. Pete and Doug, I'm going to go ahead and let you guys comment on what you're seeing here, like as the numbers are filing in. And again, this is great. So thank you guys for voting. Pete and Doug, anything that is jumping out to you here?
Doug, you want to go first this time?
Well, it is exciting to see some folks, are billing immediately after each visit. And I think I mentioned this stat earlier, about 70-80% of all practices only rely on paper only, and we've really got to reverse that. If you think of all the other types of bills you might get, like a utility bill, whatever it is, I mean, there's almost always an e-statement, a text to pay kind of option. And I'll reference back to earlier when I was mentioning I do a lot of just analysis on physician practices and hospital billing, and you would be surprised at how many of those folks are just sending a paper statement. And in many cases, that's the last thing that they touch because maybe they're short-staffed. And so even the statement processes are not even going monthly. Sometimes they're going longer because they print the statements and then they eyeball each statement one at a time. And a lot of times that will then fall behind. And then you end up with the patients who get a bill late and they're mad at you because why are you just now sending me this statement for services that were rendered months and months ago?
Yeah, that's always an interesting one. The idea of eyeballing every paper statement that goes out, right? The idea should be to solve why there's a trust issue there, of course. But I mean, I will say this about it, being realistic, you're not going to get rid of paper, right? Like you're never going to eliminate it. You're always going to need it as a potential. There are things that happen that, you don't do a good job collecting phone numbers and email addresses. Maybe someone keys one of those in or both of them in wrong, things like that. So you've always got to have that. I mean, even some specialties, it's okay that you even send a piece of paper within a 30-day period, but the goal should be, I used to send, I think the industry average is still 3.3 or something like that. Your goal should be to send one if you send one, right? Your goal should not be, hey, this is what we've always done. I send 3.5 pieces of paper and off we go. We hope for the best. You should expect that, again, if you put a new process in play, whether it's a service, a technology, a combination of the two, you should expect to drop your paper cost by 50%. That's what we see.
All right, and last one here. This is the one that I'm really interested about too, right? So if you guys had to guess, how satisfied are your patients with your current payment process, right? So this is something that I know we always hear a lot about whenever we are talking, both on the Azalea side and of course on the the PatientPay side of things, right? Like you've got your staff experience, and which is obviously very, very important, but the patient experience is tremendously important, right? So in terms of your billing and payment processes here, how satisfied are they, if you guys were just to guess? And maybe some of you guys actually put some polls or surveys out there, satisfaction surveys yourself. But if so, great. But let's go ahead again, just so we can kind of keep. I see some votes are still coming in. Last call. Give it 5 more seconds. 5, 4, 3, 2, 1. All right, end and share results. There we go. So you guys should all be able to see this now too. So hey, the first person that said they love it, man, I'd love to hear what you guys what you're doing. That's fantastic. So most of you though saying, hey, you guys the patients tolerate it, without complaining too much, and some of that I think is a bit of the sea of status quo when it comes to the expected experience when it comes to the billing process and the payment process with medical providers. But that third group getting a lot of confused calls, still a good portion of you are right there. And then of course one of you says, hey, we don't even ask. Guys, that's pretty much par for the course from what we experience both with the new prospects, right? So any color you guys want to add to that before we keep trucking?
I mean, the fact that someone actually loves paying their healthcare bill, like you said, I want to meet that person.
Someone's
They're
being
probably the most
cheeky.
positive person on earth. Or someone's being really cheeky about it. I honestly, I think I would have expected a little bit of the inverse, where the 7 would have been the calls, right? But those two middle categories, that is par for the course, right? People tolerate it. You should pay your bills, so they do it, or they chew up staff time by picking up the phone and calling. And again, we should just find ways to solve, better bills that don't create confusion and don't force phone calls, right? Our goal should be less operational overhead for staff, better experience for the patient.
That's right. I mean, understanding an EOB and trying to match that up to how much you owe, and then the statement is very challenging. And, I do this for a living and I still struggle with it at times. I'll get a bill from a provider. I'm like, okay, is this even correct? Let me find the EOB, and I may have a question. And I can tell you in my experience, if folks do decide that they're confused and they want to call and they have to wait, or they can't get you, they will get mad, and then they will complain, and then they'll tell people about it. So it's a real issue.
Yep. All right, so let's get on into some more of the meat of the presentation here. So the 80-20 rule for organizational resilience, right? So this is all about what it is that you can do, right? So controlling what you can, ignoring what you can't. So we all know about the 80-20 rule, right? So in practice, in your experience, and Pete, I'm going to start with you on this one here, right? What is it we see that are the 20% of actions that can produce 80% of the results? What are the things that people can do, these organizations can do, that will really make an impact?
Yeah, so it definitely starts with one of the ones we were talking about, your third bullet down. I think it's making sure that we're sending good bills, right? Let's make sure that the data in there is something that you end up touching wherever the patient gets that level of confidence and says, okay, yeah, I owe this, right? It's dates of service, it's locations of service, it's providers, actual practitioners they had seen, right? There's all sorts of things you want to make sure that are in the bill to make it a good bill, right? Because you never know where someone might get that level of comfort. So we need to make clear bills. And then the other thing is back to me, it's that digital first approach. But it's also, again, what we were saying earlier, it's not one and done. Not, oh, well, I sent something, nothing happened for 30 days. We'll do it again. We'll do it again. We'll do it again. Then we'll throw it over the wall to third-party collections. There's so many other tactical things you could do, a better program that you can lay out there that is going to do all these benefits for staff, obviously collect more. You're going to bring those payments forward so you don't send as many accounts to third party, which obviously will save money instead of giving away 15 to 20% of that balance it's paid. The other thing I would say, just quick comment, and sorry Doug, I'm monopolizing this one, but you put it on here, Cody, the 2-minute rule. And just in case anyone's sitting out there like, what the heck's that all about? So the 2-minute rule is something that we talk about at PatientPay, and it's this goal we have with every single go live, every new go live we have. Our goal is to see on day one, so literally day one, sending out electronic communications for the first time, do we get a payment within 2 minutes? And if you think about what that means on day one, in a lot of cases, most cases, those patients or guarantors haven't gotten a text or email from that provider. And so they're getting it for the first time, they're trusting it, they're able to get into the system, they're reviewing their bill, they're adding their payment type, they're executing the payment, and they're doing that all within 2 minutes of us sending the communication. It almost doesn't seem possible, but I'm telling you, it happens pretty much every single time. And that is the power of all this other stuff we're talking about. Make it a good bill, make it easy to get into, and communicate electronically, and you will get a better result.
And I mean, the only thing I would add to that is just, regardless of whether, and I know there's probably some billing company staff listening to this, or maybe you're staff at a physician office or a hospital, think of how much time you're spending on this stuff. You get that check in the mail, you can scan the check, deposit the check, the manual printed statements, and how much burnout that contributes to. And think of how much time you're spending on that stuff and how much time you probably should be spending on that stuff. And that's why this is super important, because a lot of that burnout comes from this. And we're spending a lot of time on, we should be chasing the high dollar Blue Shield claim and stuff like that. Instead, we're dealing with the check that was mailed. It's as simple as that.
Do either of you guys want to talk real quick about the situation? Because we talk about making it easier for patients, right? And which, hey, I can engage with it on my mobile device or whatever. I can access my bill, right? That's great if you can make it easier on and bring it to my device, as opposed to having to make me log into a portal or have those saved credentials or download an app. I don't need I need another app on my phone, like I need a hole in my head, right? Do you guys want to say anything real quick about the auto pay side of things, especially for those services like that have more of like the high frequency type services, and also the that may not apply to some of the our acute friends on the line here, but certainly the payment plans does, right? So do you guys want to touch on that real quick? Because I've seen that be some really game changers for your respective clients.
Yeah, I mean, we just had one recently. We went to an urgent care, and it was an urgent care that was recently purchased by the hospital, and we got a surprise bill. It was way more than we thought it was going to be, but we were able to go online and set up our own. We did not have to call. We were annoyed by it. Once we validated the balance, we were able to set up our own payment plan. You know what I mean? And I can't tell you how often that would save a phone call to the practice. You know what I mean? I could put my own card on file and all that kind of stuff.
Yeah.
And I've had to do that a couple times now. I had like an unexpected surgery a few years ago, and I was able to set up and build out my own payment plan. A lot of times it's interest free. You know what I mean? So you're like, let's spread this sucker out as far as I can and not owe interest on it. And I know it's going to come out, and nobody had to call anybody, and it was a good experience for me.
Why wouldn't you? As if it's no interest, right? And again, it's self-service, so it makes it easier for me as a patient, makes it easier for the practice or hospital if they don't have to field a call. Pete, anything you want to add to that?
Yeah, I mean, I think there's a couple things that you list two different things on this bullet list, so auto pay and payment plans. So I think it's important that when you have a solution, you have options like that. So it's like you said, Cody, if you're a provider sort of in a high recurrence, maybe it's therapy or other where you have high recurrence, then auto pay is definitely an option that should be there. Payment plans, of course, should be exactly what Doug said, which is like this self-service where you don't force someone to call. Like the idea of send a paper statement, and on the paper statement say, if you're interested or need a payment plan, call our office. That seems like, oh well, we want that control. There are solutions out there like ours that you have control in the beginning to set it up so that Doug can do exactly what he did, which is just accept it, right? The other thing you got to make sure is there are payment plan capabilities out there that allow a ton of flexibility on the patient side, which again on its own sounds like a good idea until you realize that you allow Doug to put in $1 a month for the next 800 months, right? So
Right.
you got to make sure
which I will try to do.
Yeah, which Doug will do. I mean, I've met him do it. No, but you have to make sure you have solutions that think about all those things, right?
Right. And Pete, just keep going here as far as the experience of Progeny.
Yeah, so Progeny happens to be, it's an interesting one because it's actually a TPA, right? But they bill for fertility services. And so it's one of those things where it's very high dollar. It's not a traditional collection problem, if you will, that other providers might have. But it's also, the payment plans don't get adopted if they're complicated, or if your process is pick up the phone and call the business office to set up a plan. Imagine how many phone calls it would have taken to get to 18,203 payment plans, right? So again, I would make sure that if you're going to do plans, make them self-service. Doesn't mean you don't control them, right? Just make sure they are self-service. Set them up ahead of time and allow Doug to sign up like that.
And again, a few more questions are coming in around that. Great. So we'll get to those here in a little bit, right? All right. So there's always the, okay, here's what it is that I stand to gain with this, right? Like, okay, great. I want to improve my practice. This promises to be able to improve my practice or my hospital. But what about this or that, right? So typically speaking, in terms of the questions that people have, like there and reasons not to do something, there's a couple of things that we see all the time, especially whenever it comes to more of this like digital first approach and self-service and those kind of things. Number one is, and this is very, very common, right? Is my elderly patients will not use this. They want paper. That's the only thing that they're going to trust, or they don't have the competency to use a digital device, right? And that is, again, almost 100% of the time, right? So there is that and what you assume about your audience, right? But then there is the reality, okay? And so Doug, I'm going to give you the first go on this, but hold on, wait for it. Boom. There you go.
Yeah. We hear, this is great because, Azalea, we focus on rural communities, and this is the number one objection. Folks aren't going to use it. We have an elderly senior population, but you would be shocked at how many not only seniors can actually use. I mean, you see the stats right there on the screen, but also like a lot of times the adult children are handling this stuff for their parents. I did that personally with my dad. I set up all his bills and I set them all up through auto pay and stuff, and I used his information and eventually had power of attorney and all that. So that happens way more often than you think. And we even had one, I'll share one anecdote. I was trying to find a good spot to squeeze it in, but when we first turned this on, when we first integrated with PatientPay, we had a client in a rural part of the country turn it on, and it was 9:45 a.m. in the morning, and by 9:47 a.m., because the texts were going out, they had 6 payments that had already come in. So people are, even though we're rural, people are used to, I get texts a lot now, hey, your bill was just processed, click here now, or you could expect an e-statement in a few days. So people are used to that. It's not going to be a shock to them. People might be, that might be part of the objection, but then by 9:54 a.m. for that same provider in a rural area, 15 unique payments had come in, and about $998 had come in the first 9 minutes. It was wild, and they were a little bit shocked because, again, rural area, they weren't really expecting anything, and people saw that text and immediately went ahead and set up a payment.
Right. And Pete, throw right. I mean, Doug, following right along your lines here, right? So rural healthcare, right? Pete, go ahead.
Yeah, so this happens to be data on a rural ambulatory provider that is exactly like Doug was just talking about, and exactly the point. Like if you look at these stats, so the one on the left, the 70% bills paid electronically, this is rural with an aging population, and this, just like almost everybody does, there was some real concern initially that no one was going to use it, right? But 70% of their bills are paid electronically, right? So they're receiving them electronically, they're using the technology, they're executing the payment, they're not writing a check. And so like the middle stat, they I forget the exact number they used to have, but they now have to handle 3 to 4 checks total per month, right? Instead of majority, 80+% were checks historically for these guys. But the one thing that I would say that to me is more telling than the other two stats is the one on the far right. So this particular provider happened to send us older balances. I think they went back as far as 3 years. So service dates that were as far back as 3 years initially when we first went live with them. And so if you think about, again, all the things you need to do or the tactics or the right solution to get action, right? Action is response, signing up for payment plans, making a payment, all that stuff. It's one thing to get it when you just went to the doctor 2 months ago, right? Or a month ago, and you expect it. It's a whole other animal that you went to the hospital or you went to the doctor 2 years ago and you get a bill, and then people trusted enough to pay it. So we got all those old balances and collected 25% of everything we got, which again, I wouldn't say that happens all the time, but that tells you that, you got to have a different solution that thinks about, again, all these different tactics to get people to use it.
Right. All right. So we're talking about objections here, right? So number one is, oh, my elderly patients won't use it. The second is just, and now nobody comes out and says this, like that I'm afraid of making change. I'm afraid of making the wrong decision. Nobody outright says that, but that's human nature, right? We know what we know, and what we're doing today, how we're acting, the way that we're dealing with our practice or a hospital. That's what we know. It's the way that we've always done it, right? And so it is familiar, right? So that familiarity does give a certain sense of safety, because at least I know what I'm dealing with, even if it stinks, right? I at least know it, right? So change is always scary. So, practices, hospitals, they're always afraid of making the wrong decisions. Especially again, like you're trying to do more with less. And if you are a community hospital, a critical access hospital, right? You're a hospital that means a ton to that community, and you've got the thinnest margins you've ever had, right? So if you make a wrong decision, it impacts the bottom line. That's a big problem, right? So we understand that. Pete, you want to say anything to that as far as what we experience, and the same thing for you, Doug, right after that too, about about making potentially the wrong decision here.
Yeah, I mean, I will say, Cody, I have heard, someone say, changing vendors is really hard, which I would get. I certainly get the comment, but then it really goes to, okay, what, number one, what's the objective, right? If your objective is status quo, then okay, then don't even bother looking at other solutions. But if your objective is to, get better results, then you go to the level of, okay, well, I've vetted some solutions or vendors, and now what? Like, you do want it to be easy to make the change, right? So it becomes important, and I'll give a shout out to the entire Azalea tech and product team that, we're business partners, we're integrated, and what we've done with them is at a different level than what we've done with other integrations. And in our world, integration at a very basic sense is I get billing data, new bills and updates, and then I send back payment data over here. But then there's the level of truly integrating so that if I am an Azalea practice or facility, I can be in Azalea, right, and get into and perform functions in PatientPay, right? That different level of integration. And that's by far the hardest part. And so making it easy to transition to a better solution, if your two, tech partners, in my example, Azalea and PatientPay, have done all the heavy lifting and done a good job working together, it's actually easy. Like I would tell you, once we're integrated, we take a new Azalea practice or facility, you can take them live in 7 days, 5 business days.
Right, and that's the key. You will be surprised that if you go to your EHR vendor, they've probably already got an integrated solution like the one we just mentioned. So the lift is not that crazy. It's just a matter of reaching out and saying, hey, what are my options? What does it look like? And then what I think is really cool too is you could, if you're worried like, hey, what if it doesn't work? One simple KPI that you could use to kind of track the success is you just take all of your patient payments that you've posted for a time period, divide it by the number of patient encounters, and do that every month. And what you will probably see, and what you will see, and what you could then point back to show the results is like, hey, my average collection per patient has increased since I've implemented this, just by doing that simple math. Number of patient payments posted in a time period divided by visits, you will see a trend upwards, and then that will be all the validation that you need. The last thing I'll mention too, if you're maybe on this webinar and you're not on Azalea and you're like wondering, well, what if my vendor doesn't have like an integrated solution? And if you're in a rural area, there's the Rural Health Transformation Program out there, just to give a shout out to that. There is funds, that rural communities have access through their states that you could use if you did need to acquire, new technology.
Solid pro tip right there. All right,
Mm-hmm.
there we go. And Pete, you want to say anything about Iran General Hospital?
Well, I think it's just another example, whether it's rural or aging population, it's another example of the right solution will drive the right results. And again, I would just point out the one that's in the middle. The stat that's in the middle is probably the most relevant or maybe even surprising one. If you don't know, you would expect again that there's a lot of opt-out of electronic communication, of electronic, billing or electronic payment. So if you've got a sub 2% opt-out, then it means that aging rural population is telling you it's fine to communicate electronically. They prefer it. And then if you look to the left, if you get a 78% collection rate, then you're actually converting, right? You're getting that main value prop that you want and need, which is more dollars.
There you go. All right, so we've talked a lot about some of the stats. We've talked about the industry. We've talked about what some other organizations are doing, right? But let's get into what at least like our experience would look like in terms of how somebody would deal with it, and provide a bit of a visual component to this. So Pete, you want to walk through this part right here?
Yeah, so this is, as I'm sure anyone can tell, this is mimicking what the patient or guarantor might experience with a mobile device. And so, if you go from the left and someone gets an electronic communication, in this example, text, of course, back to the idea of all these tactics and why you get high conversion rates and you get anyone to actually use it is, again, you don't make it difficult, right? And Cody made a comment that I think is spot on about, you might say, or an IT staff might sit there and say, hey, let's high five each other. We have a portal, people can go pay online. Well, the real question is, do they use it, right? Do they actually pay online? Or is it just another reason for them to pick up the phone and call your business office and say, I'm confused, right? I tried to create credentials to get into your portal. I forgot them. You need to reset, blah, blah, blah. Instead, you go from the first image to the second, which represents securely allowing someone to get in with a piece of demographic information that they are not going to forget, right? There's other things going on in the background that make it two-factor authenticate, make it super secure. But the point is you want to make it really, really easy to get in, right? And then once they're there, the middle graphic, you should make it easy for them to understand what you're asking them to pay for. And there's all sorts of things you can do to summarize that information initially, allow people to drill into details should they need it. It's one of the things that we do as a technology company is we utilize technology to watch user interaction, right? And so we sit there and watch. I don't necessarily do it, but our tech team watches to sit there and see what someone does, and do they drill into details? Do they scroll up and down a lot? All that stuff. You might be surprised that most patients or guarantors will notice who it's from, right? They'll see what the service date was. They'll see what location they went to, and they'll never move off of the summary information. And that summary information should include, if you can't read it, it includes things like original charges, all the contributions, whether it was insurance or their own contribution with something like copay, right? And then that's why the resulting amount is, a couple $100. As long as you explain that at a summary level, most people hit that orange button and go in and pay. They don't drill into details. They certainly don't know what billing codes are, right? They don't need to know. So anyway, a lot of things you can do from the billing side. And then once they're comfortable and they hit that payment button, then you got to make it easy. You got to offer options, which those radio buttons on the second to the right image represents. You got to give them options to pay it in full, utilize that payment plan, right? Other options if you have them that auto pay, all that kind of stuff. Give them options so that they can quickly get in there, plug in their card or their account, or use Apple Pay or something, and then pay it, and then give them a confirmation, right?
All right, so now let's walk through this. Of course, the PatientPay and Azalea are integrated solutions here, right? So Pete, again, you want to keep walking through this. We just talked about the patient experience, right? But as far as like what a user would experience, like what does that typically look like?
Yeah. And I would say, look, this represents what is really ideal. If I'm a staff member, right, I'm working in a business office, I'm a staff member and I'm talking to a patient, all right, I'm answering a question. I want a really easy way to access all the relevant information. And that might be, bill details. It might be exactly the bill or exactly the communication that was sent to that person, right? And so this is the stuff I was talking about that we built with Azalea, where utilizing what's called smart links, right? The thing on the right where you got the little highlighted circle, you can go directly from Azalea, drill into PatientPay, and Cody, you can probably just hit the next one.
Yep.
You can drill directly in there and review the bill, answer questions about the bill, and then you can even take a payment, right? So you can see everything that the patient could see. So get in there, answer questions, and execute the payment on their behalf. What's nice about that is even for all those patients and guarantors that got a text or an email, what you're not doing is you're not sitting there answering some questions and going, okay, why don't you go hit that link I sent you, right? Go back there and do it yourself. No, you want staff members to be able to, sign them up on payment plans with a couple of clicks, take a payment in full, all that stuff.
Again, it's pretty simple in terms of the way it's done, but that simplicity means that it can be executed easily, right? So, all right. So here we are. We are at let's see, 12:47 East Coast time. Sorry, I jumped ahead on this Q&A slide just a bit earlier. My apologies for not being as efficient with clicks as I could be. But let's go through some of the questions and answers here. Now, I will say as a reminder for those of you that do need to bounce off this thing, there'll be an exit survey. Please complete that. Take just a minute or so to complete that. We'll send you a $10 Amazon e-gift card just for taking your time to do that. So thank you very, very much. All right. So let me do this. Let me go over to the question panel, and I'm going to try to get through all of these pretty quickly. So Lourdes asked, actually, let me go from the start. Okay. What primary services are outside the deductible? Does that resonate with you guys?
Say it again. What primary services are outside the?
Yeah, and again, if that question, because we have other questions here too, so if that's not, if we need to ask for clarity, that Danielle, that's from you. If we need to ask for clarity from Danielle, then we can certainly do that. But
I mean, I would say it would apply to a copay or a co-insurance too. I know we spoke about the deductible, but these solutions would apply to any patient out-of-pocket expense.
right behind that, there was a follow-up question from Danielle also. What's the rule for taking cash up front during the deductible season? You know anything about Doug? You might know something a bit more about that.
I think it's best practices. And a lot of times your system will have a benefits and eligibility tool that could tell you like, hey, have they met their deductible, whether they're in network, out of network. A lot of practices, and sometimes it's hard to nail that number down because you may have to put a CPT code in to figure out, to triangulate. You're like, all right, if we're going to do these services, how much? So what I see some practices do is collect a flat amount up front, like a deposit, if you will. So that way they're not trying to reverse engineer the exact amount to collect. And then that way, they've collected something up front, especially if they've been able to verify eligibility and see that they have not met their deductible yet. So I think that is a best practice. And what I was going to mention earlier too, that I would recommend to everyone is that all physician offices, business office, billing companies need to have written instructions for their staff on how to communicate what's owed. All right, don't leave it to your front desk staff to try to figure out how to communicate this. They need to have protocols of what to check for, how to ask for the money, how to explain why they're asking for the money, and then know what the options are. So in exception handling, what are you going to do if the patient says, well, I don't want to pay you, or I can't pay you? Like, what you don't want your front desk staff having to figure that stuff out on the fly. So there needs to be a written policy and everybody needs to be trained on it. So that way everyone's on the same page as far as how to ask for that money and explain it and collect it and everything else.
Appreciate that, Doug. Thank you very much for that. All right, so a question from I may perhaps like a Azalea customer here. This is from Lourdes. Does Azalea RCM provide these services to their customers? So Doug, obviously I'll kick that to you.
We do, yeah. So, and it's one of the things that we've really taken on the last few years. It's like, hey, we need to have a digital first approach. So as a service, we will enable it, and it's already, integrated into the system. So it makes our lives easier, obviously, because the patients have less friction to pay, and we're able to get those payments posted faster. And it's an easier setup because, like Pete was saying, it's something we've already built on the integration side. The thing that practices need to do, and Pete mentioned this earlier, is we have to be collecting those emails, the cell phone numbers, communicating to our patients during check-in and registration that this is an option, because if they're not giving you that information, we're stuck with a paper statement.
Excellent. And Lourdes, that was your question. If you do have a follow-up to that, certainly ask it. Lourdes, you did ask a question a little bit further down the stream here. What's the name of the integrated solution? Well, I hope that this screen that we have up here is helpful for that. So that is PatientPay, and that's our gentleman here, Pete Heydt, is from. He's president of PatientPay. And by the way, you can see both of these fellas' names and email addresses right there. So if you've got something after this that you want to discuss, maybe you want to dive deeper into, just experiences, best practices, whatever, or you want to take a demo of the solutions or whatever it is, well, there you go. There's a good way to get a hold of those guys right there. All right, so Pete, this one, I'm gonna put this one over to you, and we'll see how much you can answer this. Tough question. Iran General Hospital District's financial statements for the year. Now, that's not really a question, and it ends with ... but I'll let you infer maybe what they're asking.
Repeat that non-question. What was it?
Yes, Iran General Hospital District's financial statements for the year. So, and Dan, that's you're the one asking that question. So if you want to clarify a bit more, maybe of what you might be asking about or whatever, but I think it might be just sort of generally speaking, what are the numbers that you see, maybe from a net patient revenue or just collection, anything like that you see?
Well, I mean, I think maybe the nature of the question is, are they doing better, right? Because I wouldn't necessarily, I don't know their details, nor am I in a place to share it per se. That being said, maybe the question is more, are they in a better place financially versus when they started? And yeah, the short answer to that is yes. And so there's always, there's certainly when you come off of a paper only process and you add digital communication, you add, an easy way for people to go in and pay, then yeah, there's always an uptick. They are definitely collecting more. I would probably have to go back and look and give an exact number to what their paper cost reduction has been. But again, I would say in most cases, and I think they're similar, it's probably minimum 30% reduction. It's probably a reduction in phone calls to the business office.
Okay, Dan, my apologies. You're right, that that question was cut off. All right. So for a second, Dan, give me just a second here. I'm gonna look at your question and try to like wrap my mind around it. Right. So, but I'm gonna go to another question while I do that. What if the practice is already signed with a third party rev spring? So Doug, that one is going to be more over to you.
Yeah, I mean, so most vendors like Azalea may have more than one option that can do the same thing. I will say that we have multiple ways of using like a statement vendor with a merchant services vendor. So that could also work. So in that situation, if we're not already using RevSpring for merchant services, we could integrate PatientPay.
Perfect. All right. So Dan, you did clarify, right, too. And again, I was looking further at your question, right? So basically, Pete, and this, I know you kind of summarized this, right? And maybe with Dan, we can provide some more of those numbers perhaps later on or whenever Ron does their annual reporting. but basically it was saying that they've been operating at a loss since 2023, right? Not unlike many other hospital districts or critical access hospitals, right? But as far as what you know for 2025, and I don't know how long PatientPay had been working with Iran General Hospital, right? But do you know like how if they're operating going from red to black at this point? Do you have any line of sight into that?
I mean, I don't know if they've officially gotten into the black at this point. I'd have to dig in and talk to them and obviously see if they're comfortable sharing and all that kind of stuff. So I don't know. I do know that for our specific function, they are doing better than they did prior to us. I do know that.
Right. And that started around, was that Q3, Q4 2025 that they started
It was
using
in
Patient?
20, yeah, it was in 25. I'm trying to remember the exact date, but I would say call it middle of 25,
Okay.
maybe
So
beginning of, yeah.
Dan, that's a really great question, of course, right? And it's going to be really interesting to see how the annual reports do come out to see how that's been trending. Okay. All right. So, is there an additional cost for the RCM clients to turn on this feature? So, again, that's the continuation of some of those other questions that Lourdes has been asking. Doug, I'll start with
I would
you.
just
And
ask them to reach out to us and follow
yeah,
up because it depends. It depends on when they sign their contract with us. It might have been included back then. It may not have. So we could look at those individually if they wanted to see. It may already be on there. It may not be. It just depends.
excellent. Great questions, guys. Another question here: can I set up the parameters of my payment plans? So Lourdes, you're welcome on that last one. Pete, you want to take that, like in terms of the question about payment plans and setting up like the specific parameters?
Yeah. Yeah, it's a good question. So the short answer is yes. You basically, at least with our solution, the way it works is you set up those parameters initially. And so you set up parameters like what's a minimum amount that you would accept a plan? Let's just say for argument's sake, you don't offer plans anything under $100. And then you also set up the tiers that help drive the number of installment payments. So you could say things like, 100 to 250 bucks, we allow 3 payments. 251 up to 500, we allow 4 or 5 installments, so on. And there's no limit on tiers. You just create the structure based on your policy. You also have the ability to do it a little more dynamically where you can have a set of plan parameters for someone who's insured versus someone who is pure self-pay, or you apply the same rules to both.
Have you seen anybody use the $1 for 80 months plan?
I've seen 2 people. One is on this call. That's Doug. The other, no, you can't do that in our system. Right? But I have seen people do that in other systems because they allowed a full partial payment or flexibility to create their own plan. It still does exist. So
Right.
if you want to look at that.
There you go. All right. So we are just about at time here. We've got, according to my timer here, 60 seconds left. So Doug and Pete, is there anything else that you guys want to say to the audience? Any other final words of wisdom or anything like that that you guys want to put out there as we wrap up?
Just good luck to everybody. It is a tough time of the year, and hopefully they got a little something out of this they could take back. And yeah, happy 2026 to everybody.
Yeah, I would just say, look, there definitely is a better way, right? It's one this is one of those functions where everybody's like, yeah, this is just the way we've done it, and it's not the claims, it's the patient side. There is a much better way to do it. It will drive better revenue results. So I wouldn't downplay the importance of it. I think Doug made that point right out of the gate.
Excellent. Well, guys, thank you. I appreciate it. And so again, this session is recorded. We'll get that over, get the session over to you guys after this. And thank you so much for being here and spending this this hour with us. And thanks for the questions. This has been an excellent session. Pete, it's a pleasure and an honor. Doug, same to you. Thank you guys so much for being here and imparting all the wisdom. Thank you very much.